welcome back. You know, we had, right before we left, we talked about we were beginning to look at the causes and looking at treatment. Before we move on to treatment, I'd like to continue on with looking at the actual symptoms. Okay? So let's take a look at some of the physical symptoms. We have a drawing that perhaps you could help us take a look at, okay?
Right.
Let's see. Now some of these words are pretty clinical,
yes.
So perhaps you could explain this to us in lay language.
Okay. Well, beginning in the upper left, microcephaly simply means a small head.
Okay.
And what that tells us, it's head circumference. The skull grows around the brain, so if we have a small head size, then we have a small brain.
Okay.
And that's not the good news, okay? The palpebral fissures are the length of the eye openings. Epicanthal fold is an additional layer of skin in the inner eye. I believe, okay, the word anomaly means something, it's a dysmorphology of birth defect, something that did not grow the way it would normally. The philtrum is the groove that runs between the nose and the upper lip, okay? And then I don't know what the micro, I don't know what that is. I'm assuming it means the chin, you know, something about the chin, but I don't know exactly what that would be.
It looks like we've got the flat mid-face.
Yes.
And then a lower nasal bridge.
Right.
Okay.
Right.
And like you said, if someone has a diagnosis of FAS, they probably won't have all of those.
Right.
Okay, but
Right.
they're going to probably have some combination.
The most common, where they look when they measure for the possibility of this criterion is the T that is formed by the eye and the nose clear down to the upper lip. And then they do the other things as well. But the major areas that are measured are the head circumference and then that T area.
Okay. Okay, so in terms of, you mentioned diagnosis and what they look for, your numbers are probably more up to date than the numbers I used in my monologue.
Well, they're different.
They're different,
than what I heard. They're the numbers that I've obtained from the study in Seattle.
Okay.
Is that approximately 44% of the babies born to women who drink either chronically or binge drink are fetal alcohol syndrome.
Okay.
And then the estimate is that fetal alcohol effect is 3 to 5 times greater than the numbers. So whatever those numbers would be, you could multiply by the...
Okay, so that's a much larger sample than the figures that I had. Okay.
Yes.
Well, in some ways that's scary, isn't it?
It's very scary.
Okay.
It's very...
Okay, now the last set of symptoms that we did look at were the central nervous system syndromes, and that's where you're talking about that there may be some damage.
Right. Exactly. Well, the central nervous system, as I said, is the brain. And so when we have central nervous system dysfunction, that means that we have brain damage.
Okay.
And there is quite a range of the possible dysfunctions that can occur. Learning disabilities being one, developmental delays or developmental arrests, perceptual disorders, which means problems with how the information gets into the brain through the senses. Okay. Coordination problems, fine and gross motor, ADHD, behavioral problems, problems with impulsivity, a whole series of things. And then last but not least, diminished intelligence. Now, people used to believe that in order to be FAS you had to be retarded, and that is not the case at all. Diminished intelligence is how the language is now worded, because the average IQ in the current information of a person, an individual with fetal alcohol syndrome, is 79, which is above the cutoff point for mental retardation. And the average IQ of fetal alcohol effect is 90. But you see, it's not about IQ, it's not about that at all. It's about how they organize, it's about whether they can live their life, and a lot of them have a lot of trouble with that.
Well, I know when I was working for a long time with mentally ill people who had also received a mental retardation. That's where I did my internship for several years. And one of the things we would measure is not just intelligence quotient, but also life skill
Right.
intelligence, because there are many people who might receive maybe a lower IQ number,
Right.
but their functioning in the world was higher,
Right.
and
Or
vice
vice
versa.
versa, yes.
Yeah.
Yes.
So it sounds like that same process
Right.
happens here.
And that's really helpful information, because I see your chronicity and I measure you at however old I see you. But if in fact developmentally you are 12, 13, 14 years old and that's what you're able to do in life, then I'm going to judge you very negatively because you're not following through. But if I have the information that your life skills ability, your adaptive living skills are really very, very low, then I will not have the expectations that would be so abusive to you.
Okay.
Otherwise, if that makes sense.
You know, that makes perfect sense.
Yeah.
Now, we didn't have the actual description of fetal alcohol effect. So maybe you can differentiate that for us.
Fetal alcohol effect is known maternal use of alcohol, or highly suspected, and that doesn't mean like we think she did. It means maybe the woman is gone or dead and the husband said she drank the whole time, or the mother, you know, something like that. Okay. Fetal alcohol effect is any one or two of the 3 criterion for diagnosis of the syndrome with known maternal use of alcohol. That's an important component, that known maternal use. Okay.
Okay. So otherwise, you wouldn't be able to attach it to alcohol, and then it would just be
Right.
a learning disability.
There is a change coming out of the Institute of Medicine, but it's more for the, you know, it's a medical diagnosis. You and I cannot make the diagnosis. It has to be done medically. And I feel very strongly that it needs to be done by people with the training in dysmorphology or genetics that would be able to identify the symptoms. Otherwise, we might miss a lot, you know. So they're trying to make some changes, but I think that's probably a little bit too refined to discuss, you know, in this kind of setting.
Okay. So in terms of, what was I going to say? How many specialists are there in this area in terms of medical doctors?
Boy, I can't give you an
Okay.
absolute number, but there's certainly, the state of Nevada, we have 4 that are specially trained. Now, that does not mean that there aren't others that may be diagnosing, because all that it says is that you have to be a doctor. But in terms of the special training, which I feel real strongly about, we have 4 that I know of.
Okay, so this is still a real developing field.
Oh,
It's
definitely.
very new.
It's wide open. It's a kind of a y'all come now if you like. If you're interested, come on. We need you. You know.
Okay, so really there's a need for research, there's a need for specialists. And in fact, well, obviously that's one of the reasons you were down here, I know, is to train local treatment providers to be able to train their people
Exactly.
specifically about this.
Right. One of the things that I think about to myself is for every new door that I open, there's like 4 or 5 doors behind it. There's such an incredible need in this field, you know. One being in your own area of treatment. You know,
Absolutely.
There's quite a need there.
Absolutely. We were talking before the show about my desire to look at learning differences, learning disabilities in the chemical dependency treatment. And
Right.
obviously this would be an important component.
Yes, when you think about what we know about intergenerational use of alcohol and drugs, I believe that one of the disciplines that sees a higher percentage of their clientele would be these folk than any other discipline is treatment, because of that intergenerational use.
Yes.
And treatment is basically very academic. And in my area, adults can be washed out of treatment for doing things that would be academic as opposed to going out and using again, you know, which to me, if it's because they can't do it because of how their brain's functioning, then boy, that's a real problem. So
we have a whole area to teach people about
Explore,
in terms of how we do it. How
Yes.
fun, huh?
yes, it's very much fun.
Okay, well let's take a look at some things we can do.
Okay.
Some things we can do about this. Recommendations for supporting fetal alcohol syndrome and fetal alcohol affects children. One thing we can do is observe a child's patterns of behaviors and identify those that reflect developmental stages and tasks which may be independent of a chronological age. And we'll have you explain that very long sentence in a moment. Hopefully you memorized it, okay?
I figured it out myself.
And then we can recognize and modify our expectations regarding those timelines, providing structure rather than control, and allowing time for transition. We'll start with those. But in terms of, probably what you were alluding to before, which is making the difference between what's going on for you chronologically and what your capability might be.
And in our society, one of the things that is a reality is the older I get, the more discrepancy there is probably going to be between what is expected of me and what I'm actually able to do. And therefore, there's going to be a stronger reaction from those watching me, because they will see my chronological age with the expectations attached to that. And then their response to me will be very, very negative. You know, so. But yeah, that's exactly what that first sentence is talking about, is that discrepancy.
Okay, so I would imagine, as you're saying that, what comes to my mind is the potential for more child abuse.
Oh, definitely. They're very difficult. Not always. I hate to be absolute like that, but often they're very difficult children to be around. And if we don't even understand what's going on so that we can put it in that framework, then yes, it definitely ups the ante for child abuse. It does, yes.
And I would think there'd be, in fact, that would become even more crucial point with FAE, the effects, because you can't see it.
Exactly.
So you're not sure what to attribute it to.
Of the three symptoms, the three criterion, the one that is most commonly missing is the face. And so you're exactly right. FAE is referred to in the literature as the invisible disability, the invisible handicap. Therefore, you look at me, you see normal, you expect normal, you punish me for something other than normal, and it's really a mess. Yeah.
Okay.
So the first thing in terms of intervention is a real thorough assessment.
Okay.
Find out not only what my intelligence quotient is, and I'm not even sure that's very important, but some people think it is, so, but my achievement level and my developmental age.
Okay.
And this information will then help me know what I can expect from you, and also know what level I need to come in if I'm trying to help you with learning, okay? And then another thing that I always train people to do is believe, see, there's so, like you said, the invisible handicap, and then a couple of the things that the central nervous system things often result in are that you can tell me things that you don't necessarily understand. So you tell me something, I think you've got it because you told me. Then I expect you to be able to follow up on that with behavior. And when you don't, then I punish you. You know, so to believe what you're seeing is true, believe what they're telling you is true, and then modify accordingly. A huge thing is they were often very, very disturbed by environmental stimulus. And I'm not talking a truck driving through the room. I'm talking just normal, like for us it would be the technicians just walking around. That doesn't bother us. We're able to communicate. If we were had the kind of disability that we're talking about, we might not be able to focus on each other at all, even though they're being very discreet and very quiet, you know, that kind of thing. So the first place I always instruct people to start is the environment. Modify the environment. Remove stimulus as much as possible.
And it sounds like, because we have just a few, 30 seconds actually, but that's okay. It sounds like the other piece of that too would be to look at transition, look at change. The change might be hard.
Either prepare for change or eliminate change whenever you can. You know, don't have them change. Yes, that's another one that's very disturbing for
Okay, so, and which would require structure, which means as a parent,
predictability.
If I do it, I better do it the same every single time.
Every single time, sometimes using the same language. I mean, not sometimes, always, actually.
Okay. I want to thank you for taking time out of your seminar and coming in.
It was fun.
Appreciate it.
Yeah.
I want to thank you for joining us. Stop by next week when we take a look at adult children and siblings of the mentally ill. I'm Mary Crocker Cook. Good night.
For topic suggestions, write to Bay Area Psychology at 1723 Hamilton Avenue, Suite A, San Jose, California 95125, or call at 408-448-0333.